So today is about fluoroscopy, and it's about a particular exercise that we will come to, but fluoroscopic skills are very fundamental to many things that are done in orthopedic surgery. And as we get more and more minimally invasive and try to do things with less risk and less harm, and it's not just about band-aid incisions, it's about decreasing complications and calcaneus fractures and all those sorts of things. Understanding how to interpret fluoroscopic shadows, being able to keep up with changes in technology as 3D is more and more in the operating room, and all those things are going to be intimately part of your career. To put it simply, I often say in trauma we are addicted to fluoro. Why would you ever want to put screws and direct drill bits without having that machine there? If you've got it, use it. It is intimately part of what we do, and you saw that just looking at the images. There are multiple skills that live in fluoroscopy. Some of them are knowing anatomy and interpreting anatomy to two-dimensional gray shadows. Some of them are bringing two-dimensional anatomy that you're looking at on a screen back to 3 dimensions, and how do you interpret in your mind, how do you look at this view and change it to that view and understand what you're seeing in two different two-dimensional planes and interpret that back to 3 dimensions. Some of it is understanding normal shadows, and clearly in my world a lot of it is understanding abnormal shadows. Why was that shadow of that posterior facet abnormal and not where it should be? And what did it mean, and what did that shadow mean in the 3-dimensional anatomy? And at my level, I could interpret that it was abnormal. I wasn't good enough to interpret exactly what it meant. If you had a full characterization, you could probably look and say, well, when that shadow changes like that, it means it's rotated clockwise in this and that direction. So none of us understand it fully. You all should be experts for your career and for the people that train underneath you on radiation safety. If we're addicted to it, you need to know those parts of it if it's part of what we do. So it is part of today, and I certainly would charge you to read that module and know that module. And a combined OTA AAOS group that is working on this same subject, fluoroscopic skills, and they're working in a different way than we are, and I'll describe that to you. They also have their introductory part of their module is radiation safety, and I think they've written a different thing, but actually Jen Coe's is very good. So very important and fundamental. So radiation safety, anatomy, understanding how 3-dimensional anatomy becomes 2 dimensions, understanding how 2 dimensions relate back to 3 dimensions, and understanding that in normal anatomy and pathologic anatomy are all very much part of the game. Working the machine is part of the game, and while in standard practice it's not felt to be good form for you to do that as a clinician, on the other hand, guiding your radiographer technician to be able to do a good job for you to understand what you need to understand. I'll often say to the more senior group, do not make your decisions on bad views. Work until you get good views that you understand, and knowing how to get those views in restricted spaces and between legs and shooting across other shadows and all sorts of things is very much part of what you want to do. None of all of those things are directly what we're going to do today. So I've left off the one skill that today's focused a little bit on understanding the shadows in 2 dimensions and 3 dimensions will be part of today. But as you get to using instruments, the focus does become in a large portion of what we do in trauma, a chunk in spine, foot and ankle, peds sometimes, occasionally adult reconstruction, certainly hand surgery. Their techniques are different because they can rotate the part easily and they can use mini-C, but a lot of the same things is driving surgical instruments, often a wire or a drill bit, and then that becomes a screw or something else, and they start in a place that you want to start and get to a place that you want to end, and understand fluoroscopic shadows in multiple dimensions to be able to achieve that. And often it's boiled down to saying navigating a wire. Wire navigation has become a trendy term. I don't know whether it's a good one, but you know, being able to navigate a wire that you'll then put an implant, typically a screw, over into a very precise place, and understanding the skill of identifying an entry point. You know, a little bit like we did with the drill bit and the depth gauge exercise, often an entry point that's deep under a soft tissue envelope, that you don't have it all sitting there like that for you to look at. So understanding the tactile feel of what it feels like to have, let's start calling it a wire, because that's what we're going to do today, and that is most common. But again, sometimes it's a drill bit, or sometimes it's hammering a blade plate or other things, and it's all the same skills of understanding where you're going. But let's start to talk a wire. What's the tactile feel of a wire being in the right place, and how does it relate to the fluoroscopic shadow that you're seeing, and how can you understand the anatomy and what you're trying to do. So if you look at what we do in trauma, you know, it's part of drilling every drill across a tibial plateau fracture, or putting a screw into a calcaneus, or again, virtually everything I do, fixing a proximal humerus. But the classic ones are putting a wire into a difficult area of anatomy from a little incision on the outside and using fluoroscopy to direct it to that spot. So if you think of iliosacral screw, now that's become a modestly common, accepted technique. You work on the outside of the butt, on the outside of the soft tissue envelope, and you use fluoroscopic shadows to get from there into the center of the S1 body. It's pretty remarkable when you think of it, that we can actually do that, and that you will actually, in 5 years, acquire the skills to be able to do that. You know, start out that far, and by twisting fluoro in a bunch of different directions, be able to safely put a wire into the center of the S1 body with thinking of all of the things that are around that area, including major vessels and spinal cords and nerve roots and all of those sorts of things. You know, we're also running wires in a lot of other places around the pelvis, and again, those are the highest level ones where it's easy to imagine you need to acquire a tremendous amount of knowledge and a fair amount of skill to be able to successfully do that. The most common one, and we keep getting closer and closer to what we're going to do today, that is part of widespread orthopedic practice, is to put a wire into the center of the femoral head. And while that is not as challenging as putting it into the center of the S1 body, it is a universal orthopedic procedure that is practiced all around the world. It is typically not done by high-level subspecialists, and it is a fundamental, basic skill. And in current practice, or in practice over, since I've started, it is learned in the operating room on patients, typically by PGY1, PGY2s starting to be given their first opportunity, with zero previous understanding of any of the things we're talking about today. And just saying, well, you've seen somebody do one or two, and at least it isn't as dangerous as the S1 body, so let's just have you have a few tries at it. And the idea of today, and I think this has been a bit of a long story. I think the two most fundamental skills that anybody would say of all you're doing this month that we could impart on PGY1s, maybe beside learning how to sew and put on a cast, is basic arthroscopic skills and basic wire navigation skills into a femoral head. The models for arthroscopic skills are advancing, but they're maybe a little bit more established. There are problems with changing the paradigm of education for this wire navigation skill from the one I've just described, which is when you're a PGY2, start having a shot at it in the operating room. And the problems are that the models are not readily apparent, and at least standard thinking would say it requires fluoroscopy. You are acquiring a fluoroscopic skill, and fluoroscopy is expensive. It requires a machine, it requires a technician, it has radiation safety issues, and you will have fluoroscopy down there today. But part of what we're doing back to research is wanting to compare a non-fluoroscopic training exercise to the real fluoroscopic one. So that's part of what you'll be doing today. The two major innovations in being able to start to give PGY1s or 2s practice on this skill without real fluoroscopy are in a virtual reality haptic environment, and that's the one the AAOS OTA group are working on. So there are at least a couple, one of which we've tried here, company that will set you up a laptop computer, give you a trigger on the outside, show you two-plane fluoroscopic views of proximal femur on the screen, and through this trigger you're holding, through haptics, give you the feeling of having a device on the side of the bone, and judge your skill to navigate into two planes into the center of the femoral head. And it isn't bad. It clearly isn't real, but it does give you some of the feel, and obviously radiation is gone. And OTA, AAOS are putting together modules based on this device. Last time I looked, it cost about $20K, so it isn't cheap, and we haven't purchased it here. And Geb and his team and Don have been working on an alternate possibility, which is to use electromagnetic tracking, and you will have the opportunity to practice and be tested on that device today. And we did it last year, and back to the grant, it is to do these types of experiments and broader and prove whether this device is a good way to learn it. So it is also radiation free. It is a drill and a bone, so the skill is closer to the real skill, and instead of fluoroscopy, you will be tracked with electromagnetic trackers that will then on a computer screen show you the two dimensions of what you're trying to achieve, similar to what the fluoroscopy does. So what you are trying to achieve is to put the wire deep into the center of the femoral head. Has anybody read about tip apex distance? So you do need a little bit of fundamental understanding, and as I think I talked to you about in one of the early days, that the way I look at these skill sessions is that you should have understanding of what you're doing to the level of having the background of why it's important, so the cognitive knowledge that is necessary to support the skill. On the other hand, to practice and understand this skill today, you don't need to know the whole world about hip fractures or the outcome of intertrokes or the history of intertrokes or the difference between femoral necks and intertrokes, but you should have a fundamental understanding of tip apex distance, because you will be trying to do that today. So tip apex distance comes from an article of Mike Baumgartner's, who's at Yale, and I don't remember exactly what the study was, but they basically looked at a large series of Yale and maybe other northeastern intertrokes, and they looked at a series of cases that succeeded and healed with a standard screw and plate implant, and they looked at a series of cases that failed, and they compared the two, and one of the differences that they found was making this measurement. And of course, we had all known for long that where the screw went in the femoral head was important back in my training in the early 80s, or when Mike was training wherever he trained. But we didn't have a quantitative measure of it. It was a gestalt that you put the screw either in the center of the femoral head, or if you were off, a little bit low and a little bit posterior, and that's sort of where I trained. And it's sort of been converted to tip apex distance, which eliminates the low and posterior, and it just says the important point is deep in the center of the femoral head. And essentially you're making a measurement in two planes of how far you're away from that. And the more you get right close to the center and deep, the better you've placed the wire. So that's tip apex distance, and you will be being tested today on your ability to do that. And it has, with reasonably good research, been shown to correlate with outcomes in anywhere you were training around the country, or anywhere you were doing cases, whether you do them here later on or anywhere else in the country. If you were at different training, they would be talking about tip apex distance and trying to get you to get the wire into the center of the femoral head and deep. And again, that's basically the concept of it: center and deep, and center on two planes. As you start to do the skill, you will see that there are multiple components. You have to start on the bone, and I don't remember just how the exercise is being done today. You may be given the starting point. If you do, that simplifies the exercise a little bit, because when you go to the operating room, nobody's giving you the starting point. You have to figure that out, and you sometimes have to figure it out from way out here. And you're essentially trying to go up parallel to the femoral neck, and so that projection is going to take you to where the starting point should be. So you have to be in the right spot to navigate into the center, going up the femoral neck like that. We don't try to do high angle. We used to try and do high angle, which would be to skirt across the bottom. We now mostly try and go right at 130 degrees or so, right up into the center. But that's only one plane. You could do this, and your wire would not be in the bone, and it would look great on that plane. You'd be perfect. Perfect starting point, great spot. You go to the other plane, and it's not even in the bone. So you have to solve problems in two planes at once, and that's part of the skill you'll be trying to get today. So you have to be in the center of the bone. Again, it's plumb easy if you're looking at it like this. You would never do that. You wouldn't even think about it. You'd be in a spot, you'd look at it, you put it right in the middle. But when you are using fluoroscopy only, you have to understand those things by looking at two different planes and a little bit feel. Does it feel like I'm on the bone? And a little bit understanding. You can expedite your ability by understanding what clues you can get in one plane of what's going on in the other plane. So if you're looking at the coronal plane like this, and you have made a starting point, and you have an overlapping shadow of the edge of the cortex and the tip of the drill bit, you know that you aren't right on the other plane. You have to be, for it to be right, it should be a point on the edge of it like that. At least you know you're close then if you're like that. Whereas again, if it looks like this, you've got a nice overlap like that, you know it's wrong on the other plane. So again, that's some of becoming more experienced. I can learn something about the other plane from what I can see on this plane. So that's the starting point. Then, having accomplished the starting point and gotten that right, you then need to use your two planes views to direct your hand correctly like that, and direct your hand correctly like that. And I think just thinking about that ahead and what you're trying to do is helpful. It can be perfect on this plane, but if your hand is like that, it isn't going right. And again, that's a skill you will try to acquire and understand and practice both with real fluoroscopy as well as with the electromagnetic fluoroscopic free, and you will be tested in some of these things, again, back to doing research, but also practicing and trying to become skillful in that fundamental skill, which is putting a wire into the center of the femoral head. remember, again, I've already tried to make the point, this skill that you'll be working on translates to many, many of the things. You know, it's all the same of trying to put a wire down here like that. You know, what is the starting point? What is my hand doing in this plane? And what is my hand doing in that plane? And how can I use the two views to help me understand that and keep my hand still in one plane and understand what is happening in the other plane? It isn't easy, same as I talked about, you know, depth gauge skills. You know, I see, you know, a 5 helping a 3 doing a nailing just, you know, 10 days ago, and understanding what you're seeing in this plane and how to move your hand. And it sort of starts to apply to reducing fractures that you're reducing fluoroscopically. You know, if you get the fluoro and this piece is like that and this piece is like that, and you're looking at it in one plane, how can you translate in your mind what's happening in the other plane and put that all together? And you know, for some of you this will come easy, and for other ones harder. It's a skill you probably, again, it's something you don't generally do, interpreting 2 dimensions to 3 dimensions. So I think that's that's pretty broad background without any of the specifics of what you're doing. And again, I don't know exactly the order, and Geb and Brian Westerland are going to help with all of those things. But that's sort of the overview of what I see of the importance of fluoroscopic interpretation, which is huge for a variety of reasons. The importance of radiation safety. Obviously, I think it's very, very important that you incorporated the fundamental nature of the skill of driving an instrument and looking at it in 2 planes. I think it's a really important day and one of the most fundamental ones. Questions?
How the structure for today?
Because there are 2 different exercises. So there is the electromagnetic, and then there is the real fluoro, and we're interested in comparing those, and we are also interested in starting to understand the effect of a test itself. So any of you with a scientific mind could easily say in one of the exercises previously this week, if we do a test and then you train for the day doing PVC pipe or whatever we're having you do, and then we do a test again at the end, and you're better at the test at the end, we don't know for sure whether you're better at the test at the end because of the training, which is what we'd like to improve, or whether you're better at the test just because you're doing the test the second time. So there is a little bit of that built into today, and I think you're actually being divided into 2 groups of 3, and one of you will, at least for the testing part, skip one of the exercises and just be retested. But you all have opportunities to practice on both of the devices. So the answer is yes, but there are 2 additional complexities. One is that, and one is the fact that there are 2 different devices or 2 different ways to train on the wire that we're trying to compare to each other. We would like to say that practicing with a radiation-free, modestly cheaper than a haptic device is a good way to start to acquire this basic skill. And you know, my feeling, you know, everybody loves reality, and you know, the more, you know, you were talking to me about Dr. Mendoza, and you know, we were putting screws and all of that, and orthopedic surgeons have forever. You know, the more real it is, the better you like it. On the other hand, we should be interested in what are simple ways to become skillful. You know, even if it doesn't have tremendous face validity, but you know, your hand-eye coordination gets better by just doing this simple exercise again and again and again. And I can tell you that people's hand-eye coordination or understanding of two-dimensional and three-dimensional shadows is far from perfect midway through training. But on the other hand, to put people into devices and make them spend time with them that aren't terribly realistic without proving that they offer some benefit isn't very sensible.